Okay, so as Dr. Brown said, I'm Lizzie Hovis. I'm a perinatal psychiatrist at MCW. I'm really excited to be here, and I'll be talking about marijuana use in pregnant and postpartum people. As Dr. Brown spoke about earlier, this is an accredited activity for continuing education. My portion of this is really going to focus on rates of perinatal marijuana use, what the evidence is that we have related to maternal, obstetric, fetal, childhood risks of in utero marijuana exposure, and then what we do with the information we have. So what are professional society recommendations? What are physicians recommending? What are doulas recommending? What are we recommending to the people that we work with and we serve who are using marijuana up and around their reproductive years? And before diving in to that stuff, I want to level set and make sure we all are familiar with the language. So when we're all of these words kind of get intermixed and intermingled and used interchangeably, but they all mean different things. So sometimes it's helpful to just, even for myself, when I'm working with patients, to remind myself of what these things mean so I know we're talking about the same thing. Cannabis refers to any compound that comes from the plant Cannabis sativa, which has over 540 chemical compounds in it, two of which include THC and CBT, probably the most well-known compounds. Or sorry, cannabinoids refer to anything that comes from the cannabis sativa plant. Cannabis is the plant. CBD and THC are two of the over 540 chemical compounds contained in the cannabis plant. THC is responsible for the psychoactive properties that can come from ingesting or smoking or applying usually marijuana, because marijuana is a THC containing compound. CBD, on the other hand, does not have those psychoactive properties that we see with THC. And that's why in places where marijuana has not been legalized from a recreational or a medical standpoint, you still will see CBD containing products being marketed and available widely over the counter without prescriptions, just used frequently. And that's because by law, CBD containing products have to have less than 0.3% THC. So you wouldn't expect the psychoactive properties from that. Perinatal marijuana use is increasing. Well, I'll talk about that in a slide or two, but there are risks that certain people are more likely to use marijuana during pregnancy. And that includes individuals who are younger, who are single or unmarried, or perhaps if they're in a relationship with an individual who uses cannabis. If they have a lower income, a lower educational status, if they use other substances, like if they smoke cigarettes or drink alcohol or use other drugs, they are going to be more likely to use marijuana in pregnancy. And then primary pregnancies, individuals without a history of other pregnancies have a higher likelihood of using marijuana into the pregnancy. I would imagine this is probably not surprising to anybody, not too mind-boggling, but marijuana use is increasing both in the general population, which you'll see in the bar graph on the left-hand side, and then the pregnant population as well is kind of mirroring that increased rate as well over the last 20, 25 years. And that's for a variety of reasons. So probably the most obvious reason is the increased accessibility, and that increased accessibility goes hand in hand with legalization. So 24 states plus the District of Columbia have legalized marijuana for recreational purposes. And then there's a variety of other states that have also either or legalized it for medicinal purposes as well. So that legalization leads to this general social acceptability. If you think about it, from marijuana use, people are more likely to do things that they think, from a human behavior standpoint, that they think or know other people around them are doing, right? It makes it feel more socially acceptable. And then with it being used in medicinal ways, for therapeutic properties like pain relief or nausea or appetite or sleep, you hear people talking about marijuana use with this perceived benefit and this perceived safety, right? There's this underlying thought that this is something that is safer to use than, say, tobacco or alcohol. And then in the pregnant population specifically, perhaps even safer than prescribed medications. People will, it's not uncommon for me to have patients prefer to use marijuana than a medication that I may be prescribing for things like anxiety and depression because they perceive marijuana as natural and perhaps thereby safe. So this brings me into a study that I found really interesting and helped inform my practice when I work with people who use marijuana during pregnancy or lactation, because it really just highlights why people continue to use it during pregnancy. And that is there's that perceived benefit, like I talked about. So this study was done by Vanstone et al., and it looked at not that many people, about 50 people, 30 of whom were pregnant, 22 were postpartum and lactating. And there were three big reasons that marijuana was used in this population that they were finding when they interviewed these people. And they found one of the reasons was symptom management. So managing chronic conditions or pregnancy-related conditions. The one that comes top of mind for me is nausea and vomiting. I have a lot of patients who really struggle in that first trimester with nausea and vomiting. It's really interfering with their ability to function, with their ability to maybe care for older children, to go to work, to engage in previously productive, beneficial activities. And so then that leads to depression and anxiety, which then further exacerbates their perception of those physical symptoms. So it gets a really bad cycle. And some of these patients will say the only thing that helps with that nausea and vomiting is marijuana. And then this is the perfect example, the epitome of someone who is using marijuana for symptom relief. Another reason for continued marijuana use in that perinatal period is coping with unpleasant experiences of life. So I think about that with individuals with really significant psychosocial stressors. Say maybe this was an unplanned or an undesired pregnancy, and it's causing a lot of stress, coping with that pregnancy. And then the third reason is probably what we all think about in the non-pregnant or non-perinatal population, which is more so for like sensation seeking. So fun, enjoyment, relaxation. And what this group found was that when they compared the reasons for using marijuana in individuals preconception, during pregnancy, and postpartum while lactating, there was a much greater emphasis on symptom management and a much lower emphasis on sensation seeking during pregnancy relative to pre-pregnancy and lactation and postpartum while lactating. So I keep this study in mind. I keep these graphs in mind when I'm working with individuals who use substances in general during pregnancy, but maybe particularly marijuana because of that, wanting to take care of themselves, wanting to treat a symptom that's really negatively impacting their quality of life, and especially a substance and with marijuana being perceived as safe or natural, that you can understand why someone would want to use that during pregnancy and into the postpartum period. And that perceived safety isn't just, it's not only in non-pregnant people in the general population. A large national sample of pregnant people said 70% of pregnant people perceive slight to no harm of marijuana use during pregnancy, and a cross-sectional national survey on drug use of over 2,000 pregnant people found that 1 in 5 did not perceive any risk with weekly marijuana use in pregnancy. And that perception of safety varied based on sociodemographic factors. So if we go back to that slide that we looked at earlier, with the risk factors for perinatal marijuana use, a lot of these same risk factors go hand in hand with individuals who perceive marijuana as being safe during pregnancy, which makes sense, right? pregnancy, we all of you on this call who work with pregnant people, have probably experienced that this is a super, super motivating time for people, who, if this was a desired planned pregnancy, a lot of these patients want to do what's best for the pregnancy. And so if they're continuing to use the substance during pregnancy, to take a step back and remember, give them the benefit of the doubt that they may be perceiving that as safe, and natural and not harmful to the pregnancy or better than alternatives. What are the risks? So I'll talk about limitations of data in a couple of slides specifically, but I do like to preface when I talk about the risk of marijuana use in pregnancy, this is really difficult data to make sense of. So not only is this actively evolving data, with marijuana becoming more commonly used in pregnancy and more, from legal perspectives, more readily available to study this population. We are getting more and more data. At the same time, the data is still limited and the data is really inconclusive in a lot of ways. And we'll talk about what the limits of the data that we have are. But with the data that we have, what we see is like very objective information or cannabinoids cross the placenta and they transfer into human breast milk. So we do know that there will be fetal exposure if you use cannabinoids during pregnancy, and there will be infant exposure if you use marijuana use in the postpartum period while lactating. Risks do appear to be dose dependent, and two fairly consistent risks that we see across studies are an increased risk of low birth weight and an increased risk of preterm labor. So if we're using marijuana during pregnancy, we're going to be more likely to have the go into labor early and have a negative impact on birth weight. As it relates to congenital birth defects, the data is mixed and inconclusive. We just don't have the data to say whether it increases the risk of the more common birth defects. There are studies, and a lot of the studies out there focus on neurobehavioral risks with perinatal marijuana use. This last point on the slide shows that in utero exposure to marijuana is an independent risk factor for the child going on to use marijuana before the age of 14. And then those neurodevelopmental, neurobehavioral, other neurobehavioral cognitive risk factors include potential negative impact on attention in children who are exposed in utero to marijuana, potential negative impact on motor skills and quantitative skills at 3 years old, memory, verbal, and perceptual scores at 4, IQ at ages 3 and 6, sustained attention and self-control at age 6, reading, arithmetic, spelling, underachieving in educational performance at 10, impulsivity, problem-solving capacity, comprehension, and rudimentary planning at ages 9 to 12. There is not enough evidence to say whether there's a causal relationship between marijuana use during pregnancy and autism spectrum disorders, because the studies that are out there are mixed and inconclusive as well. And we just don't have data to really make sense of it. As it relates to the risks of, going back to this with the neurodevelopmental outcomes, there was a study that just came out this year, actually, that did show some negative outcomes with executive function in children who were exposed in utero to marijuana. So there's increasing data kind of supporting these negative neurodevelopmental, neurobehavioral outcomes longer term when we're looking at children further on in life after they were exposed in utero. If someone's using marijuana while nursing or lactating, so marijuana is really lipophilic. It hangs out in fatty things like breast milk. And there was one study, it's just one, it wasn't replicated across other studies. It did show a milk to maternal serum ratio as high as 8 to 1. So I don't think that's consistently seen in all studies comparing human milk human milk levels compared to serum levels, but we do see a higher amount of marijuana concentrations in human milk for people who use it daily, chronically, relative to serum levels. The mean half-life of THC in breast milk is 17 days. So that's a really important thing to keep at the top of your mind, because you will see patients who do things like pumping and dumping, right? If they smoke marijuana, during while lactating, they may pump and dump, but that's not going to work unless they pump and dump for 2 weeks. So 17 days is a long time for that to hang out in your human milk. So you want to just educate patients on that so they are informed about, decisions, and they know a lot of people are surprised by that, and they may make different decisions knowing that information. The studies that do look at relative infant dose, or the relative amount in an infant serum versus the maternal serum, when you take those levels at standardized times, showed that the RID was 2.5%. So not really high. It's not like a huge transfer rate. The transfer via human milk, you would think theoretical risks to neurodevelopment, given what we've talked about with in utero exposure to marijuana. And then there have been case reports of lethargy, infrequent and shorter feeds with infants who are exposed to marijuana via breast milk. There is a potential negative impact on milk supply that's been seen in animal studies, and then a theoretical interference in a parent's ability to wake to care for infants. So that's if you think about strands specifically that lead to more sedation, may make it difficult to wake to care for infant, particularly in those early postpartum days when infants are feeding every couple of hours. Now, limitations of data. I think it's really important to approach all of this work with humility, right? Like, we do what the best that we can with the information we have, and the information we have is very imperfect at best. So the limitations include, how is the rate of the presence of marijuana use in a perinatal patient actually recognize? Is it through self-report? Is someone asking the person face to face? Because I know if I ask a pregnant person if they're using substances, they're much less likely to tell me than if it was like in a survey that they could fill out on their own time. Or if you had biomarkers like urine drug screen or serum levels. So different studies assess the rates of substance exposure, including marijuana exposure, in different ways. And so they're all very heterogeneous. It's very hard to standardize across them. There's a lack of standardization and information related to the dose and the composition. So the the composition of what people are smoking, whether they're vaping, whether they're taking edibles, while they're using topicals. This has changed a lot in the last few decades. You see down below, it says in 1993, the average THC content in cannabis was 3.4%. In 2019, it was 14%. So it's really different. And that's comparing apples to oranges then, when we're looking at studies from those two times. And it's really difficult to know what people are smoking, because not everyone's getting this from a dispensary. And furthermore, even if it's coming from a dispensary, these things are not regulated. We don't know what else makes up the product that they're consuming. A lot of the studies don't specify the gestational timing of exposure, so that's challenging to control for, because we know there's going to be different risks when someone is exposing a pregnancy in first trimester during organogenesis versus third trimester, for instance. And then I think perhaps most intuitively is it's really challenging to control for confounding factors when we're making sense of the findings in this population. So how do we know that some of these negative outcomes are due to or cannabinoid exposure versus other things that may go hand in hand, or co-occurrence of factors that may go hand in hand with using cannabinoids during pregnancy, such as smoking cigarettes or using alcohol or using other substances, or maybe having an unstable social circumstances. Perhaps someone's struggling with unstable housing. Perhaps someone has untreated mental illness, and that's why they're using marijuana. So it's really hard to control for that when we make these determinations about the risks. We do the best that we can, but there may be other co-founding factors that we're not really making sense of. So what do we do with that? With the limited information that we have, that's difficult to say slam dunk, yes or no. At this point, because of the limited information and the slight lean towards negative outcomes associated with marijuana use in the perinatal period, both during pregnancy and during lactation, ACOG recommends the avoidance of marijuana during pregnancy. AAP recommends pregnant and breastfeeding women avoid marijuana use. And then the National Council of State Boards of Nursing really emphasizes considering the available evidence and weighing risks of of the marijuana exposure to the risks of perhaps, what someone's using the marijuana for. And if you're unsure, there's lots of resources available to help. You don't have to do this alone. Certainly, we at the Periscope Project, we love talking to all of you and helping you through cases as they arise. And I know Dr. Brown in the Addiction Access Program does a phenomenal job also helping with these things. So that's what we're here for. You don't need to do it alone. Although I don't have any doubt that you are all doing excellent work when caring for this population.